This is particularly a set of questions regarding the surveillance burden, disease burden estimation. And so the major problems we identified in the European region is that some countries are still lacking the information on chronic hepatitis surveillance. About only two-thirds of member states are conducting surveillance of chronic hepatitis B and C. Then the second problem we could see that many countries are still lacking the data on disease outcome surveillance, like mortality due to late-stage liver disease, liver cancer, and also only two-thirds of the respondents have collecting the data on HIV and hepatitis C co-infection.
It's quite a remarkable situation given how many people living with HIV in the European region are co-infected with hepatitis C. This isn't the same in the whole world, but in our region there's a high level of co-infection, yet many countries are regularly collecting the data at a national level. So without the basic surveillance, it shouldn't stop us from taking action. There's enough people in care, linked to care, that we need to provide prevention and counseling services to, treatment services to. But it makes it difficult to model what is the real situation, or not even to model, to really understand the real situation. I know the ECDC, European Centers for Disease Control and Prevention in Stockholm, the European Commission's agency, is looking into carrying out denominator studies. How many people are out there? What's the real prevalence? We don't even know this. It's a situation akin to TB, HIV co-infection some years ago. Obviously, some countries are doing a fantastic job. In general, our findings are showing that things are a little worse off in Central and particularly in Eastern Europe. But awareness is growing greatly. WHO Europe is holding a strategy review. There's the global strategy. Things are starting to move quickly, but in that process, we're missing a lot of cases, and action by governments, particularly high-level action, is still ongoing quite slow in some countries in the European region.
The high level of co-infection is mainly due to the similar transmission routes of those two infections. As we know, particularly in the European region of WHO, and particularly Eastern Europe and Central Asia, the main route of HIV and also hepatitis C transmission is intravenous drug use. So this is the most affected group, and which is also aggravated by the problems in the policy, particularly in some Eastern European countries like Russia and some Central Asian countries, which prevent from effective prevention measures in this group.
So what we know among the European region, a large number of the people living with HIV who have hepatitis, viral hepatitis, it's not the reverse. The numbers for hepatitis are much, much higher than the numbers for HIV. That's globally and also in Europe. But where we have injecting drug use-driven HIV epidemics, we have concomitantly high levels of hepatitis co-infection in countries where we don't have clean needle and syringe distribution, where opioid substitution therapy, like methadone or buprenorphine, is not only available in a very limited fashion, but even in some countries simply not available at all to tens of thousands of people in need of it. They inject with contaminated needles and syringes and spread the infection, and hepatitis spreads much easier than HIV.
Currently, the WHO is working on the global health sector strategy on viral hepatitis as well as HIV. And at this moment, regional consultations are taking place in different regions, and we are organizing the regional consultation in Europe in the end of June, and we are expecting the active participations of member states, of hepatitis experts and civil society.
This whole issue around knowledge translation, knowledge transfer is a big and a crucial one. Now we have a cure for hepatitis C. We've had a vaccine for hepatitis B for a long time, and yet why are we still seeing not just so many existing cases, but so many new cases and often so little government action? So one of the things we're doing is, as we mentioned, is writing up the results for peer-reviewed journals, but then also taking them forward to the governments, presenting, trying to discuss with them. And what we found also was that it's actually very difficult to get this kind of material published. So many of the hepatitis journals are fantastic, high-impact journals, and they're very biomedical, basic science focused. So one thing we're doing to remedy this is we're going to launch, likely on World Hepatitis Day, the first open access hepatitis policy journal. Actually, it'll be hepatology, medicine, and policy. So freely available, you can download the article wherever you live, at any time, forward it, upload it again. And we'll be trying to attract the kinds of articles that deal with service delivery, adherence, policy issues, even some surveillance issues, epidemiology, and so on. Just as in the field of HIV, where we've been working so long, we have so many different journals publishing so many aspects, from travel restrictions to AIDS and behavior and so on. We're going to try and do that now in the field of hepatology, and quite urgently in the field of viral hepatitis B and C.